present to their doctor with something like pain that's shooting down from their neck to their hands, or tingling or numbness in their hands wasn't there before. Issues with balance when they're walking, because the spinal cord is related to the walking and that component too. Something like that, or if they have issues with extreme neck pain, these are typically issues with degeneration of their spine. So when patients present to their doctors for something like this, what they end up is sometimes they get physical therapy, they get these these conditions managed in a conservative manner, traction of the neck and some of these things. But when some of these conservative measures fail, typically they're referred to us for evaluation. Do they need further pain injection that we can refer them to? Do they need an operation? What kind of an operation? Do they even need an operation? That sometimes they just need closure to understand what their disease is. And so a lot of time is there. So that's the neck part, but again, we see patients for lower back problem, which is much more common. That could relate to, again, aging, could be remote trauma, could be work-related issues as well. So some of that, again, depends on what symptoms they have. The most typical symptoms are back pain that's radiating down their legs, pain that gets worse when they're standing upright or they can't walk for a prolonged period of time. Things that have changed over time specifically and affecting their mobility and day-to-day activity. So a lot of it actually depends, what they present is a change in functional status. So more than that, what we like to offer is improve their spine health to provide them with the functionality of what they were before.
Dr. Vasquez, I'd like to ask, carrying through a little bit more with this conversation, is there are symptoms, you're talking about what people are feeling. Now, and I know that you all are surgeons, but diagnosing what the issue may be so that now the surgeons know what they need to do. How is, say, I'll even use me. Cervical, I think 5 and 6 is all messed up. I've got some spurs in there. I'm always walking around like this. When is it that I need to go see a surgeon? I mean, I've done physical therapy. I try to keep my, stretching going on. But diagnosis to the point where now I come see a surgeon. When and how does that come into play?
Well, under many circumstances, really, this is the question that the patient asks himself, when do I need to go and see the surgeon? And the fact that you are referred to neurosurgery does not mean that you are going to have neurosurgery. You are not going to have surgery.
Nicely said. I'm glad that you said that.
And I think we have to stress the importance of the surgeon being also an educator. Because you go and ask the patient really what type of activities you do during the day, what type of work you do during the day, what is your posture, how do you do this precisely, being on the computer all the time, sitting all the time with your neck bent over.
Exactly.
So the examination many times will let us know that this is mostly a problem of muscles, really, that the patient needs what it needs is a good physical therapy, good postural exercises, and then the cooperation between a multidisciplinary approach is what makes the difference. So we have physical therapists that we refer the patient to. So when the patient comes with deficits, what we call deficits is already because they have weakness in the muscles or they have atrophy, then that is pretty much almost a surgical indication.
Okay, nicely explained. And again, Dr. Gasco, this goes beautifully to you now. So let's just say, and we kind of throw out fake case studies out there, or even one that you've got in the back of your head, that seems to be a relatively easy case. Let's say someone's got neck pain, has had neck pain for years, has tried everything else, tries to do surgically now. What do we do? And think of, again, just any case study, explain to the audience, as surgeons now, what are you doing on the operation table that is helping this patient out?
So once we have a diagnosis.
Exactly.
Herniated disc in the neck or herniated disc in the back, like for instance, we have this model right here. And here you can see the spine all the way from the neck to the bottom, to the pelvis. And here you see this little red dot that represents a herniated disc.
Okay.
What we do in surgery...
It'll be this camera right here that has a red light on that you're pointing it to. Perfect.
What we do in surgery is basically we make a small incision centered over the problem,
Okay.
and with micro instruments we remove that problem.
You remove the problem.
Yeah.
So on that note, the problem is what?
Herniated disc, tissue that
So
has
you
moved.
take the disc and you remove the disc?
We
or
remove
you
the herniated portion of that disc so that
Okay.
it doesn't impinge on the nerve itself anymore. So you see
Okay.
these yellow things here?
Correct.
Those are the nerves. When a patient comes to you with leg pain, it's because these nerves are being compressed, either because the canal inside is tight or because there's a herniated disc, or maybe the vertebrae are not aligned.
Okay.
Sometimes we need to align those vertebrae by putting screws.
Right.
And now we do all these things minimally invasive so that patients get small surgical incisions, minimal blood loss, and we
Okay.
are capable of doing 5 or 6 segments of the spine in an hour and a half, and patients go home the next day.
Wow,
So
fantastic.
these are things
Okay.
that are not the one thing I think as a group we want to make sure the audience understand is that spine surgery is no longer the shark bite incisions from the past where you would get an incision this big and lose half a liter in surgery. Right now I think we've evolved to a point that we have 10 people in the room
Right.
controlling the safety of the patient.
In
And that's
fact,
very
your next
important.
question is going to be about robotic surgery, but let me go back to you. And the reason I said you remove the issue, so let's say you were talking about aging. So now the disc is herniated, fine, but now let's talk about a case study. As with aging, there's the disc just start
Grinding.
going away.
Yeah.
Yes. So in those situations, and it may be on the horizon, I don't know, is there a substance that can be substituted? Is there, I know you were talking about screws, what is it, say it's somebody who's 80 and is perfectly healthy and could be around to be 100, but there's that issue with the spine rubbing on each
So
other.
the grinding of the spine, when you lose that disc, sometimes what we do is we put an artificial implant in between and then we expand it.
Okay.
We expand it to the point where the vertebra gains all, the disc height is gained again to its natural status. And so basically we do this by inserting an artificial implant inside. There's also artificial discs that we can put in that have basically a mechanism that allows the neck or the spine to move. And these things have been approved, and we are certified and trained to do these things here in El Paso. And so the patients don't lose the mobility. So not always we have to fuse. There's, if you have a single level disc herniation in the neck and you're a young person, maybe you want an artificial disc.
Okay.
So these are things we can do these days.
Dr. Vasquez, take this in the most beautiful and endearing way. You are the most seasoned person on this panel, unless you're younger than Dr. Gupta. If you are, then let me know, then you've got some work to do. I'm asking this because I feel like 10 years ago, 15 years ago or so, I've been doing the show 22 years. So about a decade ago, that was still something that was brand new. The idea of inserting something to create a prosthetic disc, so to speak. I would love for you, and you still robotic man, you're gonna get there in a second, but I would love for you to kind of take us through kind of when that started becoming experimental and or case studies versus where we are today with that, because I feel like we're so much farther ahead now than we were a decade ago with that.
Yeah, you're absolutely right. Years ago, and we're talking about pretty much 15 years ago, that the possibilities of replacing a disc were entertained. The main issue was that in young people that many times suffer disc protrusions, the only answer was the fusion.
Right.
And that was not fair, because several reasons. Not only because a person would lose a segment, and we say a segment because that would be fused. And you have to consider also that involves the vertebra above and the vertebra below.
And when there's fusion, there's no
And
movement,
there's
is that
fusion,
right?
there is no motion.
Okay.
But since we still have to watch TV, since we still have to look at the car coming, we do all these motions. And certainly, those motions also cause the other segments to be more active
Correct.
and may deteriorate sooner. So the solution was the artificial disc.
And I love that that is an option, because I feel like that will be me, not relatively
Absolutely
soon, but relatively soon, because I've had, again, the same issues for a good, I'm 52, so maybe 15 years now, and it progressively has gotten a little bit worse. It's not to the point, but I do have, you know, a range of motion issue on this side.
So
yes, Dr. Gupte?
Yes, to add on to that, Catherine, I think they had excellent points, and I just want to elaborate a couple of things. When we talk about specific problems for the spine, let's say we talked about the disc herniation, it's the same surgery, or I wouldn't say the same surgery, however, the same problem can be dealt with in different ways.
Right.
Is it a surgery that can we do from the front side of the body? Can we do it from the side? Can we do it from the back of the body? And so a lot of the discussion or thought process that goes behind is we know the problem, we know how that's to be dealt with, but what's the approach? Does it need an implant? Does it need a spacer, or does it not? Does it may need a minimal invasive, just disc removal and nothing else? So like what Dr. Vasquez pointed out, we take into account not only the age and what their functionality is, what their premorbid conditions are, and what their existing lifestyle is, to take and make the right decision. So I'm proud to say actually we're—
And that's what I'm talking about,
yes.
the diagnosis.
Right.
Of one's, how does one find all that out? Again, just a lot of Q&A?
Yes, the time that you spend with the patient, understanding, you know, how much and what the right surgical approach might be for them, that's the way we will go. And like Dr. Gasco said, we typically will have a team approach. If there's a patient that we have a couple of thoughts in our mind, we will talk amongst each other as neurosurgeons and sort of go back and forth about what's the best approach to go for this specific patient and this problem. And I'm proud to say that we're conservative neurosurgeons. We will try and avoid surgery for the patient and give them the best, you know, outcome without even needing an operation. However, you know, if they've exhausted all options and this is what they're eventually needing, then what is the best way to get that taken care of?
Right. Nicely said. So let's talk about that, because I wanted to get into robotic surgery first before we go into trauma, because it's not a new thing at all anymore. But when you're looking at such specific and small spaces, and Dr. Gasco, you were talking about that too, when you're looking at robotic surgery and finding, and you can use what you were just talking about, finding out if we're going to go in from the front or the back, how is that performed? If you could, as much as you can, if you can describe to the audience at home, you all being in the surgical center, the operation room, how is that being performed?
In terms of robotic surgery
In
itself?
terms of robotic surgery, yes.
So as you were asking, it's funny you were asking the question about the evolution of artificial disc. We're in the era of evolution of robotic surgery for neurosurgery specifically.
Okay.
So we're still in very much the infancy of what robotic surgery can even do. Presently, robotic surgery is used for spine and for brain, different indications. Spine specifically is used for placement of, you know, screws or instrumentation that they need for maybe fractures or maybe their arthritis-related problems, to increase the accuracy of those screws to avoid nerve structures that sometimes are very close when placing the screws. So it helps get a very accurate result, minimizing the blood loss.
Right.
We can plan these operations well ahead of time before even the patient is on the operating room table. So it reduces the cost of needing hundreds of instruments that we don't know which one we would use. That was before that. Now we can pre-plan all our surgeries using their images before the operation has even begun.
Exactly.
So that that's pushing us to reduce the operative time, reduce the operative burden and blood loss. So some of that. In terms of brain, it's helping in accurately doing biopsies of these patients if they have tumor or suspicious lesions. So it helps us in our skill set to add the accuracy component to make it much safer than before.
Nicely said. And again, it's not new, but just recovery time. And you were even saying that some of your surgeries now, with a full-blown surgery, is an hour and a half, where years ago it'd be several hours, if not the entire day. So just being around, just the recovery on that is phenomenal. I have a question here from the audience, and Dr. Vasquez, I'm going to throw it to you first, and feel free for anybody else that would like to talk about this, because we were talking about age. A lot of things depend on age, Let's talk about what comorbidity is, because sometimes we say it, we know it, but what it means is all the other issues and conditions that you may have in conjunction with. whatever it is that you all are looking at? Or somebody tell me if there's a better way to describe
Well,
that.
for example, if someone's have heart disease, heart conditions, that because of which we're not able to perform a specific type of operation, or that is guided by the cardiologist saying the patient would not tolerate a major operation. So then we have to figure out a way to achieve the same result in a specific manner that would reduce the operative time. If the patient has a history of smoking, if they have any other history, that changes our mind towards, what kind of, how is their bone quality, how do we assess their bone quality to make sure that we are able to get them the same result if they were not smoking. So we take a lot of those comorbid conditions or associated conditions in mind to plan the surgery.
And the reason I wanted to bring that up is that we do these programs and people, go home and they think, well, this is what they said on the air and this is what, but it really depends on each individual person on what is going on with them. Family history sometimes gets involved. So that's why I wanted to bring that up. So Dr. Vasquez, question from the audience. Robert, I'm going to say your name, Robert. So Robert is 61 years old, and I'll do the disclaimer. This is all that we have to work with. So what we can give him, Robert, just so you know, it's not a diagnosis, but here we go. I had a compression fracture of the lumbar vertebrae L4 several years ago. I have had a few surgeries, doesn't say what kind, since then, but I still have a lot of pain. Is there anything that can be done? Dr. Vasquez, go first, but Dr. Gasco, since you said, you get to follow that up as well. All right, Dr. Vasquez?
Well, it's a very important issue because in the aging population, we see this very frequently. We see the frequency because of they are more prone to falling.
Yes.
So fractures is one condition, one entity that we are not really away from them. We see them very frequently in the patients. Now, it would be interesting to know what type of surgery was done with this particular patient.
I don't know if it's fusion.
Because there are conservative or semi-conservative means of addressing this issue with what is called kyphoplasty. In other words, bringing the height of the vertebra that is lost at the time of the fracture up so that restores some of the anatomy and the curvature of the spine. And from there you can go to having fixation with, as we were discussing before, with rods and screws. So it depends what type of surgery. And it depends if this is a pain that is localized to the spine or is a pain that is referred to one of the extremities. So this patient needs a close evaluation.
And that's where the neurosurgery comes in, is that feeling, that shooting pain with the nerves. Dr. Gasco.
With regards to Robert's problem, I would say that if he had several surgeries, he probably had a fixation of sorts for his fracture. And sometimes what happens is the fracture's still not taken care of. There's still motion that affects that fracture, so the fracture continues to be an acute problem. It doesn't solidify.
Right.
So what we would need to do in his case is do an MRI and then assess with x-rays whether the construct that he has moves, and then address it surgically and give him options if there are options that can make his pain better. And
so remind me, and my apologies, I should know this, L4 is where? Since you have the spine right there.
Right at the bottom of the spine, right here.
Okay.
And so assuming that someone, and we've seen a case recently where this happened, so a patient had a fusion and had a compression fracture and had several procedures, but the fracture was still active. By injecting cement, as Dr. Vasquez was saying, plus in addition reviewing whether the instrumentation that he has still, it's actually working or not working, whether if it's moving, then it's not working, it needs to be revised. And this is, you were asking earlier about the diagnosis. I think it's very important to understand diagnosis as the four legs of the table.
Right.
You have to have the patient's symptoms, the imaging studies, the electrodiagnostic studies, the radiology, all meet onto a surgical plan. If one of those legs is missing, then the plan does not work. And you need to have congruent symptoms, and they need to match your radiology, they need to match your electrodiagnosis. This is what Dr. Gupta was saying. we're conservative, and we also take a look at every single angle. You know, I had a patient that came to clinic with a neck problem, but then ended up having a back problem in addition, also surgical, and severe medical issues that had not been diagnosed.
Oh, goodness.
Just by listening to him talk, he was short of breath. So before being surgeons and neurosurgeons, we are doctors.
Yeah.
And so we have to look at the patient as a whole. And so I hope that answers
No, it
multiple
absolutely
questions
answers
at
it.
once.
Yeah, so that's nice when we get to do several.
Yeah.
Dr. Gupte?
No, I was mentioning, and it's a good question that came through your audience, and I would like to talk to, you know, and address about Robert's problem too, and at the same time I want to plug in our complex work that we do. So we do complex spine surgery. Now what that means is, in the past, if there's a focal problem of the lower back, or that used to be addressed. If there's a problem of the neck, that needs to be addressed, and that's not a wrong thing. However, we look at the entire spinal structure. We look at their posture. We look at their spinal alignment, because what the recent studies have shown is if you have a lower back problem that affects your posture, it starts affecting your neck, right? Then if you have an abnormal posture of your neck, it does tend to affect your pelvis and your knees. So patients go for knee problems, but it actually started in their lower back.
Right.
So we look at the global spine, we call it global spine health. We look at that posture and address those. So perhaps Robert has a posture problem in which we call it compensation. Is he compensating enough? Is he overcompensating that's causing these
Robert
problems?
is me and I am Robert. Seriously, you are absolutely talking.
Yeah, so I think I think we've come a long way in studying biomechanics of spine and complex spine health. I think we incorporate all of that in our practice, and we'd love to offer that to the community.
So I am going to throw, before we go into certain issues, so I have a curvature of a spine. Mine's right at the tailbone, and it's exactly right. I overcompensate. I hold one part of my body up, and then about 15 years ago, the neck started killing me. It used to come back. I need to come see you guys, right? Is that what you're telling me? We need to have the full picture. Oh, I'm all over the place. I mean, my mother, God bless her, she's been gone, many years, 25 years, but she used to say, she can hear me coming down the hallway because of my gait. There was something in German, she called it something else. So, it's like the way a horse gallops.
That's the patch.
Yeah, and so I was like, what does that mean? She goes, oh, you've never walked straight, honey. And I'm like, ah. So, Robert, thank you so much for calling in. I would like to talk a little bit now about, not necessarily trauma, but let's say now there's fracture of and maybe you can tell me, Dr. Gupta, what is the most common area if someone's going to get a fracture of the spine? Talk about a fall. I guess let's talk about falls. Let's talk about falls, because I feel like that doesn't get enough attention.
Sure.
Car accidents get attention, exactly.
Sure.
So a fall, what area of the spine most likely will be fractured?
So most likely, when you talk about falls and fractures, the most common is an osteoporotic population. What that means is the aging population in which the bones are brittle. And in a minor trauma, like just falling from a standing height, just tripping on something, causes a fracture.
Which seems to be a real simple thing.
Exactly,
but,
it causes a fracture. And so we'll see commonly those fractures in the mid to the lower back of their spine, called the thoracolumbar area, that affects and causes pain. And again, that is the most common area, I would say, that's what we see with.
Okay.
But a fracture from the trauma, if we define falls, that's the minimal trauma that can affect cause a major problem.
Right.
And then we see the extremes of trauma, which is also motor vehicle accidents, and those are obviously not falls, but they're extreme traumas, and those could be anywhere depending on the exact mechanism of how the injury happened.
Okay. So Dr. Vasquez, I want to ask you, when someone falls and they think, oh, I'm fine, I'm fine, when is it that it's like, I'm not fine? What symptoms are they experiencing? Number one, pain, fine. But and the reason I'm asking this too is that often people don't get checked until it's like, oh, now it's really broken, and now it's really this and that and the other. When is it time to go see you? And say somebody has fallen off the curb, they're just getting their mail. Oh no, yeah, that curb was there, boom, and they're hurting, but to what point is it where they have to go find some help?
Usually the mechanisms the body utilizes is the muscle trying to protect the spine. I'm talking about the curvatures of the spine or the alignment of the spine. So the muscles getting sometimes into spasm, and this may be the result of a fall that may appear trivial. You know, usually that type of pain would go away over the course of a few days.
Okay, and that's
Right.
what I'm looking at, because I think
Right.
that somebody said earlier a change in function status, which I
Right.
love. So
So when you have a discomfort, a pain that is really persistent, that is really interfering with your activities, you know, and you notice that certain motions are causing more discomfort than usual, I think that's the time that you have to refer to the physician.
exactly, and it's nice when people actually do that. On that note, let's go to Dr. Gasco, and let's now talk about a major fracture. Let's say that this is a car accident or some other major fracture. And that's something that we can't say is most common. But how does one fix the spinal bone?
Yeah.
You know, I'm looking at how one would do that. Is there fusion going on
Yeah.
there? And again, if you want to just throw out a case study that you have worked on in the past, so we can kind of understand.
Many.
Okay.
We do this almost on a monthly basis. And the last case I did was a young individual who broke his thoracic spine right up here and had certain elements of instability, so it needed to be fixed surgically. If nothing was done, this patient had risk of basically becoming paraplegic, so losing function. And so we got a young guy who needs a serious operation. What we did for him is we did a minimally invasive fusion. So what we did is small incisions all along the spine, 2 levels above the fracture, 2 levels below the fracture. At the fracture level, we injected cement to restore the fracture height.
Interesting, okay.
And then we put in screws at that segment, but were shorter so that they wouldn't break the vertebral body that was already fractured. And we did this in 1 hour.
So
Patient went home
here's
in
the
2
question
days.
that I'm thinking about if I'm sitting
Yeah.
on my couch at home. This guy comes in, it was an accident, and you know, there's a million doctor
Yeah.
shows on the air, right? So they come into the emergency room, one of you is on,
Yeah.
the other one gets called in, this and
Yeah.
that and the other. The decision-making process. The
beautiful.
crazy,
It's the
like,
best- it's the
oh,
best,
I've
part
heard
of
that
it.
it's a complete high. I've heard this from many, many surgeons. It's like, it's a high because that's what that's where the energy comes from. Describe that to me. Describe how you look at the fracture, there's an MRI, you guys got to look at it, and now this discussion. What is it that gets you to the point where you know what you're going to do?
You always want to think, what would I like if I was the patient? What
Right.
would I like to get done if I was the patient? So you got a 28-year-old, you got a problem, it needs to be fixed, and then you have to think in your mind, option A, option B, option C, and a fallback plan for every single one of those options.
Right.
So if this happens in surgery, then I do this. If this happens in surgery, so it's algorithmic thinking.
Uh-huh.
The other thing we do is when we are unsure, because there's more ways to approach a case than just one, we will reach out to our colleagues and say, what do you think of this case? And then sometimes they will say, well, consider this or consider that. And then we will come up to a beautiful agreement where there's a back and forth between us surgeons on behalf of someone who doesn't even know that 2 or 3 individuals and surgeons are talking about him. And then we see those patients leave the hospital, and this patient I was telling you about came back to clinic feeling great, no issues, we got him off his brace, he's going to go back to work, and that takes up hours of our thinking process, but it's the beautiful part of our work.
Yeah, it's a
And,
life.
Yeah,
And he's 28,
yeah,
for heaven's sake.
yeah.
Goodness. On that note, I know that we're more than halfway through our hour now, so I'm going to address this one because I think this is something we need to respect. Can an elderly woman, in parentheses, 94 years old, I love that. Number 1, thanks for living this long, and number 2, keep going, and thanks for calling in. She wants to know, and this is where the comorbidity and just issues in general, wants to know she can undergo surgery for lower back pain. Or is pain medications like epidurals her only option? Again, this is all we have, so we're going to do the best that we can with this. Who wants to take it? It's like a gamble.
No, I can
Anyone?
take
Dr.
it.
Gupta?
Absolutely.
Dr.
No,
Gupta,
I
go
think
for it.
you hit the nail on the head when you talked about comorbidities, right? So one factor obviously we're looking at is age, but that's not the only factor.
Exactly.
You know, is because we necessarily don't talk about patients in terms of age. We talk about functional status. So is it a high functioning 94-year-old or someone who is, someone who has comorbidities that prevent them from mobilizing enough? So there's more thought process that goes in rather than just the age factor. So I wouldn't want to give an answer yes or no depending on what the factors are. It's definitely, if there's a possibility of doing something. So if we just take age into account and that's all we know, we want to minimize the operative burden if we decide to do an operation. And so what do we need to do? If we decide, well, if the operative burden is going to be big and let's not go ahead with the operation, then what are our fallback options? So I think that part of that thinking is more complex than just the age component of it.
Exactly. When you were talking, this is not, I mean, we were talking about when you do surgery when you're awake. Is this spine or brain?
Brain.
Just, okay. I know we're talking this complete different thing, but I kind of want to get to that in a second.
Can also be done awake.
Yes.
Yeah. Really?
I've seen it in South Korea. They do it. Yeah.
Okay, just
here,
because
here,
I am
here we're not ready, but
okay.
because it's a mentality also. But they actually do awake surgeries in spine patients for herniated disc.
I'm a little bit freaked out right now.
Yeah.
I'm just saying, but I'm curious about this. I have one more question here from the audience, and I want to somehow pivot back to because we really haven't talked about brain. I know that we do a lot about spine, but I'd like to talk about this. Maria, I love that they're giving names. Thank you for giving us names. It makes them far more human. Oh, by the way, I never introduced, if we can throw the camera over to Aaron. And, Aaron, hold on a second. I know Aaron. And then we also have Malini. Hi, Malini. How are you? She says it's Malini like colony. These are the young medical students that are answering the phones and getting questions over our way.
Thank you very much.
Thank you very much, exactly. So Maria has had, if you have a herniated disc, can you do strengthening and conditioning exercises to help, or does this harm it? And I think the question here, help or harm, and how long is it sometimes before you're just waiting too long? Dr. Vasquez, I'm going to throw that your way, because I love the fact that you can really just wait too long, not too long, there's always chance, but can it harm a herniated disc if you're doing too much motion without trying to get it fixed?
Okay, there are motions and motions in the spine.
Okay.
Right? So there are appropriate motions, and there are motions that definitely are going to harm the spine and aggravate the problem, right? So motions that are going to aggravate the condition are the motions when they lift without the proper mechanics, they lift elements, and turn that
the twisting,
and they twist the spine, So those are motions that the disc is not prepared for. The disc is like a cushion, really, that allows really to pretty much cushion the movements of the spine and also the support, because it's attached to the vertebrae, right? But when you do this torsion, and you can take the example of the golfers, they do that precisely all the time, so many of them end up with herniated disc and lumbar surgery. Right.
Oh, exactly.
You have multiple surgeries.
So in there, and I guess a good basic question is, if there's a herniated disc, definitely before just going to work out, go check out a physical therapist or check with your doctor.
Yeah.
It's absolutely worth it before you go into
the fact that they have a herniated disc doesn't mean that they are going to have surgery.
Right, exactly.
Yeah, that is, one of the issues that the patients have to have in their mind. That is not a sentence to go and have surgery.
Exactly.
Surgery becomes almost an imperative when there is a loss of function or a loss of the sensation of one of the weakness in one of the extremities, weakness of the muscles. Then it becomes more of an imperative really to have a surgery. And the pain is a very, very strong also advisor in that sense.
Yeah. Beautifully explained. I am going to kind of switch to the brain. We have a whopping 15 minutes. This goes fast. So here's a question from the audience, and then I do want to talk about the awake surgery. But question from the audience first. I have a white spot on an MRI and on my frontal lobe, and I get spots in my vision. migraine, severe pain, blackouts. I have been getting Botox injections, and they do help, but only for a little while. What else can I do? Again, this is all we know.
She needs to be seen.
She needs to be seen. Good. So expand a little bit about that. So she needs to be seen.
white
Again, so
spot in
she's
the
already
frontal
had the
lobe.
MRI.
Yeah, so the white spot in the frontal lobe without much more information could be an inflammatory condition, it could be something else. We would need to take a look at it to better understand it. Sometimes an MRI just in and of itself is not enough. Sometimes we can expand and get a spectroscopy, so actually analyze the tissue without having to open her up and just take her to a different type of MRI and get more information on that. The second thing is her clinical symptomatology and the relationship to the Botox injections. So basically she needs to be seen. Possibly she needs collaborative approach with neurology and not just neurosurgery, and then we would give her a plan.
Okay.
But that's.
I like that. It's all about the plan. Question here from the audience. So that was Jose. Thanks. And Jose's a veteran. Thank you for your service, Jose. Gonzalo, that's a cool name, Gonzalo. Signs, what are the signs and symptoms that would make a headache an emergency? This is a great question. And I'm going to Dr. Vasquez, I'm going to you next. So let's talk about a headache that all of a sudden just comes on. When is that headache an emergency? And now we're going to brain issues, so this is exactly where I wanted to go. Question for you. And this is from Gonzalo. Thank you, Gonzalo.
A headache that become like, some people describe like a thunder really falling on that person, you know, and is accompanied many times by nausea, vomiting, and sometimes with changes in sensorium, and that is persistent. This is a headache that does not go away. You take a Tylenol, the person may be conversing, but at the same time has a headache that literally becomes intolerable. You know, and there is no Tylenol, there is no medication really that takes care of that. And may be able to go to sleep on the next day, still the headache is present. I think that's the person that should go and go to the
So let's
emergency
take it
department.
another step and tell me what might be the problem with that kind of headache. Are we talking brain bleed? Are we talking?
Correct.
Just
Correct.
throw
I think
something out there that.
we are talking about one of the most feared events for the patient. You know, the sudden onset of a rupture of what's called an aneurysm that becomes a weak spot in an artery that bleeds, and unfortunately, you know, I mean, hits many persons in the most productive age, in the 30s and the 40s.
Right.
Right. So this is a condition really that requires emergent attention.
And emergent attention is absolutely the case. So if there's just it's easy for us to say because we're all on this table together, but if there's a question, just go get it checked out. Actually, I'm not going to ask this question yet because we are like at the 12-minute point. I've got lots of questions, but let's stop for a second. I'd like to look at all three of you, and if there's something that we have not yet covered, because we could do 20 hours on this, what have we not yet covered that you wanted to get across before we close up the show? Dr. Gupta, you're first just because you're right next to me.
So I think we talk about brain and spine, but neurosurgery also involves peripheral nerves, carpal tunnel.
Right,
nerves that get pinched at the elbow
See, we
or
didn't
at
even
the
get
wrist.
to that. I know, exactly.
Right, so
Yeah.
it's beyond that, and again, neurosurgery is trauma. It is brain tumors. It also involves degenerative conditions, congenital issues, blood vessel malformations, problems, inflammatory processes. So it encompasses a range of mostly acute or subacute conditions that we help with. So I think that's what we want to get to the audience, that I think part of us working collaboratively at UMC is we have mainly the resources or the teamwork approach. For example, I do some of these transsphenoidal surgery, which is take tumors out from the brain through the nose with an endoscope, and for that.
See, that's just cool.
Right,
Next
so
time you have to bring a video on that.
We
I'm all about the toys and the videos.
Yeah,
so
absolutely.
Yeah.
So for that, we work with the combined, the oral maxillofacial surgeons. So
Right.
their team and our team, we work together to achieve this. In some of the cases, we work with the general surgeons. Sometimes, and in fact, a lot of the complex spine operations, we work together for the same operation. We have two surgeons working on to get the same results. So what we want to get across is the resources that we have, and the complement of subspecialty that we have at the hospital allows us to do that and push boundaries and to get the result that we want to get, like we want for our loved ones.
Like we want, and like you want for yourself. Yeah. Nicely said. Man, you got all energetic right there.
You got it.
Did you give him any espresso before the show? Just wondering.
That's baseline. That's me baseline.
Oh, he's always like that's my baseline.
Which is what we love.
Yeah, it's fantastic.
Absolutely,
it's fantastic. Dr. Vasquez, how about you? Is there anything that we need to expand on before?
I think expanding on what Akshay has said, we have to let our patients know that we work with multidisciplinary teams. When the patient comes with a pain problem, and sometimes we cannot address that particular issue because the pain has no origins in a medical condition that can be taken with surgery, then we refer the patient to a pain specialist. When the patient is deconditioned because has been too long with that pain in the lower back and has not exercised, so we converse with a physical therapist, so that at all moments really we are seeing the patient as an entire entity with different the cooperation of different specialties really to make this patient feel better.
And I like that. It really is a team approach, again, with all issues that a patient might have. Dr. Gasco, how about you?
Well, I would like our patients to know that at UMC El Paso and in our neurosurgery group, we really offer state-of-the-art care and surgery. The reason why I can say that is because I trained in Houston in many of well-reputed centers, MD Anderson, Methodist, Herman. And I'm actually the latest addition to our group approximately 4 months ago. And the reason why I came here is because this hospital is able to do things that are more complex than what I have seen in Houston.
Nice.
And so sometimes when primary doctors, if any of them are watching this and they feel compelled to send their patients elsewhere because they think that the matter is too complex for us to handle, you wanted to also talk about awake craniotomies. We do those here.
Yeah.
I've done several as faculty in Galveston and here. And I collaborated with Dr. Trier in one of his cases. He's not here. But we want the audience to know that we have all the technological advances that neurosurgery has. And we have the brains as a collaborative group to actually use those tools in an effective way for our patients.
Nicely said. And this is a perfect transition because we got through all three of you, and I want to talk about what did you call it? The cranial...
Awake craniotomy?
Awake craniotomy. Let's talk about that, just because I'm curious.
Briefly is when a tumor is located in an eloquent area of the brain, like motor or speech.
So you have to make sure there's function. I guess the reason is, why would you do it awake? That's the question.
You would, basically, you don't do it fully awake from the beginning. You wake up the patient in the middle of the surgery.
Okay.
So once you have actually exposed the area of the problem, that's when you wake up the patient. And so you need collaborative anesthesia, and we have that capability here. And then, of course, you have to speak to the patient during the procedure. In this case, the patient was Spanish speaking. We discussed the things with her, talk about family as we were doing surgery. And
trying to keep her comfortable.
Exactly. And so this is to the intention to not affect the areas that are eloquent and to give the patient the maximum result and be able to respect the normal tissue. And this is just an example of things that we can do, but Dr. Gupta was talking about his area of expertise, which is transfenoidal surgery, and the complexity of the tumors that he does. Many places in this country, would have a lot to envy from what we give to our patients here.
So I'm gonna turn it over to you kind of with the same question. And I'm a medical show junkie, and I know I get it's TV, I get it's the movies, I get it's not the room. But I have seen several episodes of just various TV shows where they do that and they're talking to the patient and then all of a sudden there's an arm movement or what have you. So that's why I'm fascinated by it. It would freak me out still. But we're here to teach people not to freak out if that's the case. And again, since this is kind of where your complexity and specialties lie, what would you have to add to that?
So again, I think you're kind of alluding to awake surgery and some of that.
Yes.
So when again, if we think that this may be the best approach for the patient, we also have to take into account, is the patient anxious? Because if someone is anxious, we're not be able to achieve the same result. We're not be able to wake them up and have them be calm. So we have to have a collaborative approach with the patient, assessing how the patient is and what their personality is. What can they tolerate something like this? And if not, how do we achieve the best result without doing an awake craniotomy? Do we have backup options like you talked about, 1, 2, and 3 with backups for all of them? Do we have that?
Yeah.
But I think it's having that, respecting the patient's understanding and their anxiety is a big part of neurosurgery. And our job, the biggest job I think, is when we see a patient is education, just letting them know what their problem is.
Right.
Because they have a lot of anxiety just knowing about what this is. They have no idea about this. So educating them with MRIs, with pictures, and with diagrams showing them what this is going on. And maybe you don't need surgery, but all you needed was some information, which is what, and they're satisfied just knowing that they got an explanation, they got closure, knowing what they're going through.
That's a big part of it.
From the specialist.
Yes.
Exactly, from someone who gets it. And I have several other questions here from the audience. I'm not going to go with this one. We have a whopping like 2.5 minutes. But question super fast, is there a surgery where you take out portions of the spinal column to correct hunching? If so, how do you perform it and what is it called? I don't know if there's a quick question on that. I haven't heard anything about this before. I wanted to respect
complex spine surgeries, and yes, the answer is yes, you can do it. That's called deformity correction surgery, and we do pedicle subtraction osteotomies and different things in order to correct those things. Scoliosis can be corrected with lateral approaches, and so the answer to the question is yes, we can do it. Selective cases, everything needs to be very well studied preoperatively.
Nicely said. Question here, Mary, who's 92 years old, go Mary, wants to know if her recent dizziness, vertigo might be related to a neck pain. Could it be a nerve type of an issue? We have 2 minutes left. Who's going to take that one? So again, vertigo and neck pain. She's got vertigo, dizziness.
Vertebrobasilar insufficiency is a possibility.
Okay, what the heck does that mean?
These two vessels right here are the ones that supply the back of the head, which can actually be affected with age and arthritis. If those are constricted, she gets less blow to the back portion of the head, and then she gets dizziness.
Okay.
So sometimes these patients need to be placed on aspirin. Sometimes they need to be have flow studies to assess the flow in those two arteries right here. So these are things to consider for her. So she needs to see a neurologist, and probably will help her.
Come see you guys too.
Yeah.
All right, I'm throwing this out because it says to Dr. Vasquez. I'll give this to you because it makes it famous, but you said aspirin. The question is, does being on some kind of aspirin increase your chance of a brain bleed? I know it's a loaded question with very little information. Less than a minute. Go.
Right. Go. The combination of aspirin with other medications like Plavix, for example, increases in a 10% chance of bleeding. Now, aspirin per se is going to affect the function of the platelets that form the aggregate for the clot.
Okay.
So they need to be about a week before they go through surgery, a week without the aspirin.
And then stop from there. Very
Right.
nice. I want to give out the telephone number really quick to the UMC Department of Neurosurgery, 521-7731. Again, thank you to Aaron Pines and Malini Riddle for being here. Again, we've had Dr. Gupta, we've had Dr. Vasquez, and we've had Dr. Gasco. We've been talking about advancements in neurosurgery and spinal care. And if you want to watch us again, go to kcostv.org. I'm Catherine Berg. You've been watching the El Paso Physician. Good night.